I just wanted to talk to you guys about a subject that I think is all pretty relevant to everything going on now as it's getting colder. I think this is probably actually the scary. I find pediatric emergencies to be the scariest. They are definitely things we don't love to see in the ER. We like happy babies and healthy babies, but they do come in, and with that being said, I just wanted to kind of discuss vaguely some pediatric emergencies with you. I think the thing that I want you all to take from this is not necessarily how to diagnose anything or how to treat anything. I've kind of talked about a broad range of things with each topic, but mainly just what to look for, what's bad, what's good, what sounds bad, what things you should ask, what things you should be worried about, just kind of challenging yourself with every case that you see that's a pediatric case, because when you do see the sick ones, they can be pretty scary and they're memorable, so just definitely things to look out for. So these are healthy babies. These are actually my best friend's babies. They aren't. And then just healthy kids are good. So we want happy, healthy babies. And yeah, unfortunately it's not always like this, but when it is, it's good. So I think the thing I like to just discuss with everyone is vital signs. Vital signs are the really most important thing. Sometimes, you know, a kid might not look right, and the vital signs really are going to help you realize what's right, what's wrong, things that might be off, things just to keep in mind. And then as kids get older, younger, whatnot, their vitals can be totally different. So I have this, there's a PALS note card. I don't know if you guys, I don't know if you do PALS or talk about any sort of pediatric ACLS type picture, but it's nice to just have this as a reference to look back on what's normal, what's abnormal. A neonatal heart rate is going to be totally different than a 16-year-old's heart rate, and vice versa. So just because you see a heart rate of 100 in a 16-year-old does not mean that that's normal for a 1-year-old. So just things to keep in mind. So I think one of the most important things to discuss is retractions. As it's the winter season and kids are getting a bunch of viruses and asthma and bronchiolitis and different diseases, retractions are a good way for us to examine kids and to tell what is good, what is bad, what's abnormal, what's normal. So things that I like to take a look at. First thing, whenever I see a kid, whenever you guys bring a kid to the ER, I just like to get them undressed immediately. That's the best way for me to tell how they look. Parents typically in the winter season, understandably, are bundling their kids up as expected, but you're not going to be able to see anything when they're bundled up. So I don't know if you bring a kid to the ER and you want to, if you can stay to just look at us when we're undressing them, that can really tell you the most important pieces of information. So there are different types of retractions. There's the suprasternal, clavicular, intercostal, substernal, and subcostal. Essentially the ones that are really bad that should be concerning to you guys are the suprasternal ones. Up here you'll see, and I'm going to give you guys some good examples, it kind of looking like it's like sucking in a way. Also the subcostal, so under the ribs you'll see, it kind of looks like they're sucking in, and that's really bad too. They're kind of, kids are fighters, so they're a good way to tell if something bad could happen, if there's like impending doom or whatnot. So just things to look out for. And then I have a bunch of videos. I don't know. Oh, I'm not there, the mouse. Okay, so these are just examples of retractions in different kits. Some of these are. So I don't know if you guys can see it. Is there a way to make that video? Don't mind these other videos. So if you can see, you have some intercostal retractions right there.
Where's the head?
So the head is up here. Here's the diameter. I don't know. Just one example. I mean, the kid's laying on his side right here.
So how concerned would you be about that?
So that would be more of like a mild retraction. I'll show you some more concerning ones. No, don't worry. So here you can see. So here you can see some intercostal. There might be a little bit of a subcostal there as well. A little bit more concerning. Yeah, that's because they're having an increased work. This is a website.
Here is the second child.
Sorry, thank you. So she's described, the way she's describing them kind of, I don't remember the exact word she used, but mainly look at the retractions in these kids.
Her name is Jenna. Does Jenna?
Here, intercostal. You can see the subcostal right here. There's infrasternal too. You're not seeing the suprasternal one there. This is another good example of retractions here. You're seeing a little bit of a suprasternal right here. Not terrible, but these kids are a little bit sicker, but this one, oh, I think they were using this one as an example as one that's not having retractions. So that's, no, this is normal right there. Yeah, you can go to the next one.
Hey, it's working.
Oh.
I just saw the mouse. Not the one on the wall.
And then this one is really to show you wheezing and what wheezing would sound like on a little kiddo.
Breathing. You will probably have to place your ear close to the child's mouth or use a stethoscope to hear the sound clearly. Listen to the sound as these children breathe out. The wheeze sound is often described as a musical sound, made as the child breathes out.
So, okay. So, when kids come in with, if someone were to come in with just shortness of breath or difficulty breathing, a really unknown reason as to why, there's a whole list of differentials. Things to just keep on the back of your mind. Winter season, you get concerned about bronchiolitis, asthma, and croup are the ones that I'm specifically going to talk about. But there's just a whole list of things to keep in the back of your mind. Kids sometimes, they might not really present very clearly. So it could be from some source that really doesn't fit the picture at all. I know, like, when you guys first see the kid, you might really not know exactly what happened or what's going on, but it's really important to take into account the whole surrounding, because that will really help. And then you can even mention that to the provider when you bring them to the hospital, because sometimes the whole picture of the home scenario versus and root scenario, the relationship with the parents, everything really fits into the picture of the kid and things that are going wrong. So this is just a whole kind of list of different things to keep on the back of your mind. I'm just going to discuss a few of the big ones that we see in the ER briefly. So this is, don't worry, I'm not going to go through this whole thing. But mainly when you come to the emergency room, the big thing that we're wondering when the kid first comes in addition to what's going on, is this more from an upper airway issue or a lower airway issue? So upper airway meaning like anything like trachea and above, lower more of the lungs. And there's literally a whole pathway breakdown of how you can, if you suspect one thing, then what, and what you do with each potential scenario. But just, I guess the big thing is you go in, you don't assume it's anything, you have to be open-minded to any potential diagnosis and go from there. So I have a few cases for you guys. We can talk them out, and yeah, let me know what your thoughts are, if you have any ideas or anything. So, yeah, so you have this 3-year-old boy coming in, shortness of breath, cough, and fever for a few days. Parents sometimes say barky cough, sometimes they don't, because they don't know. It's obviously very helpful when there's a barky cough, but this is probably one of the cases where, from an EMS standpoint, it's really helpful because you guys will hear the kid coughing in the house. And then by the time they come to us, they've been exposed to the cool air, so we won't necessarily hear that barky cough. So if you guys hear it, and I have some pictures or some examples, videos of it, definitely let us know, because it's really, I think, a pretty good indicator of what the diagnosis could be. So there's different types or different levels of croup, as I kind of showed you with the retractions that we were talking about, different levels of severity. Usually if the kid's coming in with a pulse ox, I'd say less than like 92, I'm more concerned about that kid. It kind of shows you that you're going to need to act a little bit faster, just because of the hypoxia. Respiratory rate and heart rate are also elevated as well.
Going backwards.
I'm going backwards.
There we go.
There we go. Yeah. Okay, so these are some examples of kiddos with croup. So I don't know if you guys can hear that. You're going to get more of an expiratory sound with inspiration versus expiration. You're going to see or hear the abnormality more with expiration. So you can hear as she's breathing out, that's where you're getting the concerning noise.
That's it, baby. Yeah, until we can go see the doctor again.
I don't know why that one's not at the doctor's, but that's okay.
Please quiet down.
So just a little bit of background information on croup. So typically board question, test question caused by para-influenza. And you're going to see this mainly in the fall and winter. Croup can progress to something even worse called laryngotracheal bronchitis. Really, I actually have never seen it, but I'm thankful I've never seen it because they're sick pretty much on death's end. So it's essentially worsening croup. So then other things, this is kind of like what I was talking about in the beginning, other things can mimic croup. So if you have a kid who you're treating that you're concerned for croup and they're not getting any better, you have to think about other things, even though they might sound like that seal-like cough, that barking cough. There are other things that could cause croup. Probably one of the biggest missed things is an obstruction. So kids swallow things, they put things in their mouth, and parents might not see it. So that's, and also bad anaphylaxis can cause these types of symptoms too. So just other things to keep in the back of your mind. So do you need to x-ray every croup kid? Absolutely not. But if you were to get an x-ray, you're going to see this kind of steeple sign, almost like pointing. You can see this is normal up here. Here's a good picture of it. You'll see the tissue is swelling because of the croup, and that's what causes this steeple-like sign. So that's another pretty big test question type thing for croup if you were to get an x-ray. But like I said, you don't, if they have the barking cough, if they're getting better with the treatment, you don't need to get an x-ray on them. Here I thought this was a pretty cool picture to show you a little bit more as to what was actually going on. So this is normal. These are your vocal cords right here. If you were to actually be looking inside, normal vocal cords right here. So with croup, you're going to see the vocal cords are a little bit more swollen. And here's a really good example. You can hardly even see the vocal cords because they're so swollen from the croup. So just something we don't see, but kind of interesting to look at when you're thinking about the disease. So the treatment, like I said, sometimes by the time you guys bring them to the hospital, the cold air will completely eliminate the cough. In the ER, we'll give these kids dexamethasone, a steroid, and if they're really bad, to the point where their oxygen levels are low, they really look like they're working hard to breathe, they're having those retractions that were concerning that we talked about earlier, then we'll give them racemic epinephrine. When we do give the kids racemic epinephrine in the emergency room, we usually watch them for another 4 hours because sometimes the croup or the cough and the shortness of breath can relapse. So we usually like to watch, we usually tell parents as soon as they're getting their racemic epi, we watch them for at least 4 hours. And if they're doing better, let them go. Do you guys have any questions about croup or anything? Yeah.
What's racemic epinephrine? Is
So-
that different than regular epi?
So it's a good question, actually. So racemic epinephrine didn't used to actually be given. It used to just be epi. It's like very similar to the IM epi, except it's in a nebulizer. So like when you're giving someone a breathing treatment, it's instead of like albuterol or a bronchodilator to open up the airways, you're giving epinephrine in a nebulizer type form. Does that make kind of sense? So it's working the same as if you were giving someone IM, but it's nebulized, so it's going into their actual bronchial tract.
Thank you.
How's croup different than RSV?
So that's a good question. Croup is, well, the most common cause of croup is the parainfluenza virus. RSV is a virus. I had never seen RSV causing croup, but croup is just kind of like the reaction that the virus causes, I guess you could say. So we don't usually test it in the ER because we just assume it's parainfluenza virus, which it most commonly is, or some other viral illness, but I mean, it's possible. All right, so we have case 2 is a 6-month-old baby girl, coughing, runny nose, looks like her shortness of breath has been getting worse over the past few days. One thing I forgot to mention earlier that's really important that we always ask parents is, are the kids immunized? Do they have a pediatrician? Were they born full term? Were they born early? Were there any complications with birth? Because if they were early, that will kind of point us in a direction of, are these kids more prone to getting sick? They could have been intubated at birth and in the NICU for months, so they probably have a weaker immune system, weaker airway than those who were born full term without any issues. So other questions definitely to ask. So here you have another hypoxic girl. Her oxygen levels in the 88. Heart rate's a little high, and respirations are a little bit high as well. All right, so here's her physical exam, or some examples of a potential physical exam. So here you see the retractions. Here you have the sternal retractions, a little bit subclavicle. And you heard that wheezing. So I don't know if you could.
When a child is brought to you with
if you think about that other one, so when you were hearing the wheezing there, it was when she was exhaling, whereas the croup kid that I showed you earlier, you were hearing it when he was inhaling. So that's a really good picture of inspiratory versus expiratory, so upper versus lower airway issue.
You should examine the child to determine whether wheeze is present. The clinical signs of wheeze include the wheeze sound on expiration. Before disturbing the child, listen to the child's breathing. You will probably have to place your ear close to the child's mouth or use a stethoscope to hear the sound clearly. Listen to the sound as these children breathe out. The wheeze sound is often described as a musical sound, made as the child breathes out.
So bronchiolitis, another common thing that we see in the ER at this time of year. So typically children less than 2 years old, they'll have the runny nose, they'll have the cough, the wheezing, and this is one where I've had a few RSV positive tests already so far in the ER. Most will be positive. Or if they'll be positive and you'll be concerned about bronchiolitis. The two kind of, I feel like they come hand in hand together most of the time. I tried to do a little bit of reading about, it's kind of tough because bronchiolitis is when they're under 2 years old. Parents will say my kid has asthma when they're under 2, but technically you can't have asthma if you're less than 2 years old. I don't know the exact reason as to why there's a 2-year-old cutoff, but So if anyone knows and wants to let me know, please go ahead. But they kind of separate bronchiolitis is under 2 and asthma is older than 2. So for these kids, a lot of the times someone will come in with really mild bronchiolitis, and half the battle is just teaching the parent how to do nasal suctioning. We have the nasal bulbs, and they have the nose fritas that parents can use too. And some parents just don't know that kids at this age are having a lot of secretions, increased secretions, and that's what's really causing them to have all of this trouble breathing, because that's really how they're getting their oxygen at this point. So just teaching them nasal suctioning every hour continuously. Sometimes that's all they need, and then they'll get better from there. The kids who don't do well with nasal suctioning will have to put on oxygen sometimes, and technically you can try albuterol, the nebulizer, or if they're really sick, you can try the racemic epinephrine like we talked about earlier. But really, those aren't going to make a huge effect on the kiddo under the age of 2. So in the ER, and I'm sure you guys will probably see us, if the kid looks really sick under the age of 2, really working to breathe with the retractions, with the wheezing, we will call a respiratory therapist down, and we have high flow nasal cannula in our ER, which is essentially a device that we use to put positive pressure, essentially like more force. It's kind of like the CPAP or BiPAP, if any of you guys are familiar with that. It increases pressure into the kiddo's nostrils to help open up the airways to get oxygen to their lungs faster and better. So some people say they don't love it. I think now studies are more so saying if you're concerned about these kids, you put them on it right away, and it can really change the outcome really fast, and it's a pretty wonderful tool that we have. So high flow nasal cannula, they really don't work well. Okay, any questions with bronchiolitis? Sorry, kind of a lot of information. Okay, last one. So you have a 6-year-old boy with shortness of breath and wheezing for 2 days. He has a known history of asthma. Respiratory rate is okay. He's statting 91% on Romair, and his heart rate's okay for his age. So this is if a kid's coming in with shortness of breath and the parents tell me they have a history of asthma, this is where it's really important to ask if they've ever been hospitalized for their asthma before, if the kid has ever been put on the ventilator for asthma before, if they've ever had any really bad outcomes before, because if it's happened before, it's something that could definitely happen again.
Now, let's take a listen to what this patient sounded like when listened under a stethoscope. I used the echo stethoscope to listen to this patient's lungs, and here's the sounds.
So he's having inspiratory and expiratory retractions, which points to our wheezing, so that's pointing to more of a severe case. So these would be the kids that you think we're concerned about. And here's a really good, I'm just happy to find this, a really good example of the suprasternal retraction, which you don't see very often.
That sounded pretty terrible.
Apparently he doesn't get it.
It's his first time, it's okay. I don't know how to treat this.
So this is asthma exacerbation. So mainly, there's a lot of little nitty-gritty things for you to think about with asthma, but the big things I want you to think about are, how does the kid look? Is the kid really working to breathe? Is he having a lot of retractions? Is he having the nasal flaring? Is he having the suprasternal retractions? And what's his oxygen saturation? I'd say though kids can be really tough to get an oxygen saturation on if they're like moving around, really agitated, it's really an important vital sign for this because it kind of tells us, it adds to the picture. it adds to whether or not it's mild, moderate, or severe. So that's why I put those in red for you guys. And like I mentioned, the severe inspiratory and expiratory wheezing is concerning for more of a severe reaction. So for these guys, we want to dilate everything. So we are giving them nebulizers with albuterol and ipratropium. And we're going to be giving them steroids as well. The steroids, there's prednisolone, there's dexamethasone. We're leaning more towards giving these kids dexamethasone now, which is more of a longer acting steroid. There's also been a lot of controversy in regards to whether these should be given IV, IM, or orally. It really doesn't matter. All that matters is the kid keeping it down. And if the kid's keeping it down, then you can give it to them orally. If they're throwing up, don't even think about it. Or if the kid's really sick, if this kid is really working to breathe and you're like, we need to get this in him right now, then that's where you would just go right to the IM. Magnesium sulfate is an interesting one too. This works adults as well. So it's essentially an additional medication that you can give that will relax the muscle around the bronchioles. So that is kind of more so held towards the more severe cases as well. So usually in the ER, my step approach is I'll go with these two to start, and then if they're really sick, then I'll give them the magnesium sulfate as well. Now the really, really sick kids, this is that epinephrine talk that we were talking about. You can give kids it as a nebulized racemic epinephrine like you would for croup. However, if they're moving around, you're concerned that they're not getting anything in,